Hello, good evening, everyone. Welcome back to my IVF Answers and the European Fertility Society. We are back with one more topic, and we've been here actually yesterday, but I'm glad to discuss this topic today. We will talk about premature ovarian failure. And if you've seen our webinar yesterday, I've already mentioned this. We will talk about causes, symptoms, and diagnosis and treatment options. And of course, we have the best person to introduce us to this topic, but also explain how it all works. Dr. Halyna Strelko is with us today. Hello, Dr. Strelko. Thank you so much for joining us back here again. Lovely to see you. I hope you are all good and are ready to educate us and inspire us for sure and share some knowledge. So, how are you? How have you been? Glad to have you here for sure.
Good evening. Thank you very much for this nice presentation. So this is a really interesting topic, and for IVF specialists and for patients, it's really important because approximately 15-20% of all patients has this problem from patients who come in IVF clinics. So today we will see the main problem, how to treat, and how to understand that we have exactly this condition, how to diagnose, make diagnostic, and what to do in generally, how to prevent.
Brilliant. Thank you so much, of course. And we will start with Dr. Strelko's presentation on our topic. But afterwards, there will be time for your questions. As always, if you have questions, just type those in the chat, and Dr. Halyna will be happy to answer them for you. I am sure of this. Remember, it's all anonymous. So if you have any questions, this is your time. This is your opportunity to ask the expert and get some answers for your particular case. And remember, it's being recorded. I hope not, but if you need to leave, you will be able to rewatch this, as this will be available tomorrow on our website as well. But I hope you will be able to join us and simply make this session interesting. And of course, we are here to support you and answer any questions you might have. And let me just remind everyone that we are just 1 week away from our 500th webinar, which is going to happen next week on Tuesday. So we are really excited, and Dr. Halyna has been a part of this actually for a few years now. So I'm glad that you are back with us and you are still supporting our My IVF Answers webinar project, and it's definitely going strong. And thank you everyone for joining us over and over again, because as you know, we are simply here to support you, and it wouldn't be possible if you were not joining us every single week at least. So thank you so much indeed for this. But now I think it's time to go ahead with our webinar and our topic. Here's the presentation, and remember, if you have questions, type those in the chat section. But now let's go ahead with the presentation.
Okay, let's start. So this evening we will talking about premature ovarian insufficiency or premature menopause. So, what is it? Why we're talking about this? So, normally, ovary produce estrogens and progesterones, and these hormones produce complex effect on whole body. All organs and systems react and changing with these sex hormones, and when level of these hormones decrease, all body will also change. We can see in this diagram that the level of steroid hormones start to decrease after 40 years old and progressively decrease if it is normal menopause till the age 60-70 years old. Effects of estrogens, we can see that not only ovary and sexual organs involved. Estrogens protect heart from action of cholesterol, protect liver, protect bones, give us young skin, protect brain, because when we have decreased level of estrogens, we can have some, how to say, not mental problem, but some some problem related to brain function. We can have sleep disturbance. We can have mood changes. Also, problem with uterus and ovary when level of steroid hormones decrease. Also, estrogen has possibility to protect against free radicals. It means that high level of estrogen protect us from changes due to late age. Also, we should talking about effects of progesterone because ovary produce also progesterone. This is the hormone which we have in second phase of our cycle. So progesterone give us calming effect in brain, reduce have like anti-inflammatory effect. Relax our vessels and decrease blood pressure, assist with liver and kidney health, also retains bone density. So a lot of effects, and when we lose all these protective effects, unfortunately, we can constate some symptoms. You know these symptoms like vasomotor symptoms, hot flush, change in blood pressure, night sweats, insomnia, vaginal dryness, mood disorders, weight gain, fatigue. You can see in this diagram that all these symptoms, okay, not all present in each woman, but a lot of symptoms and mainly 2-3 present in each woman who has ovary insufficiency. Second point, which is important, that decrease of steroid hormones produce a lot of negative emotional influence. 52% of women with premature ovarian insufficiency has a negative impact of emotional state. 88% declare to have depression. 87% declare to have fatigue, decreased performance, irritability, loss of memory and energy. So it's important to understand why all this appear and what to do, how to protect yourself. And when people understand that, they are, how to say, ready to do something. Because very often, if patient does not understand what happened, they try to see different doctors and cannot find the way to help himself. So, ESHRE, European Society of Reproductive Medicine guideline, say what does it mean premature ovarian insufficiency. This is the loss of ovarian function before the age of 40 years old. Why this age? Because the age of natural normal menopause is approximately 50 years old, plus minus 4 years old. And we can see in this slide that around 1% of people has menopause before age of 40 years old, and 10% has menopause between 40 and 30 years old, 40 and 50 years old, 48, for example. What it means that premature ovarian failure, it is this 1% of population who has menopause earlier than 40 years old. It may be also menopause at age of 30, even at age of 20. Proportion you can see here, for example, at age of 30 or before, one woman for 1,000 has unfortunately this problem. At 20 years old, 1 to 10,000. But this precocious menopause, of course, due to some genetic or immunological problem or other problem, and we will see all this problem a little bit later. So, why it is important to talking about premature ovarian insufficiency or premature menopause? Because this estrogen and progesterone deficit may give some general health problem. For example, accelerated cognitive impairment, accelerated cardiovascular disease, especially high blood pressure. Very often we can find autoimmune disease like adrenal or thyroid gland disease. Also, of course, we will see infertility because if no egg, no pregnancy, osteoporosis, which we can see also with natural menopause. But if our menopause arrive at 30 years old, of course, at 40 we will have the sign of osteoporosis. And unfortunately, also guidelines say about premature mortality due mostly to cardiovascular disease. Also important point with premature ovarian failure is feeling of well-being, of quality of life. And most of women say that they feel like very high emotional stress due to isolation and stigmation, because in most of case women don't speak a lot about that with relatives, with friends, with even with doctors. Also, problem of diagnostic, because at 50 years old women mostly are ready to have menopause, but at 30 years old even doctors not often thinking about this condition. Also, women often feel, how to say, guilty because they has, for example, a reproductive problem or some other problem. So psychological status of premature ovarian failure is really very serious condition. The main etiology of this of premature ovarian insufficiency is genetic, autoimmune, after some oncological treatment, but around 50% of all premature ovarian failure still stay idiopathic. It means that probably there is some problem, but we are not able now to find this problem. Idiopathic, this is around 50%. Genetic causes is around 10%. It may be Turner syndrome, specific genetic abnormality with only one X chromosome, also Fragile X. Fragile X, it is the mutation of FMR1 gene, and normally all donors all over the world should be tested for this condition. Other mutations also may involve from another problem. It is the more often is autoimmune problem. 15 till 20%. We can find or some autoimmune problem and premature ovarian failure, or for example, if we have premature ovarian failure, necessary to see another possible autoimmune disorders, and very often we found it. Error of metabolism also may be the problem and give us premature ovarian insufficiency. Also some infections like mumps, especially during the sex development at age of 14, 15 years old. Also some infections like human immunodeficiency virus, tuberculosis, malaria, and other problem. Also some factors like smoking. There are a lot of articles studying these questions, but a lot of articles show that heavy smoking can be associated with earlier onset of menopause. Also, big part of etiology, it is iatrogenic. It means chemotherapy or surgery or um, radiation, especially in when we are treated oncological problem, and it may produce the premature ovarian insufficiency, unfortunately. If we don't found some specific iatrogenic problem, um, currently guidelines say that there is no proven predictive test to identify women with which will develop this premature ovarian insufficiency. Only if we found some mutations mentioned above, in this case, of course, we can say that in future this woman will have this condition. But otherwise, there is no some specific predictive test. Only if we will check ovarian reserve and we start to do it quite early, we can detect that ovarian reserve is lower than should be for this age in women. In this case, unfortunately, there is no some specific preventive measure, and we can thinking about fertility preservation and thinking about reproductive plans earlier than should be with normal ovarian reserve. Uh, the diagnostic of premature ovarian insufficiency is based on presence of menstrual disturbance, oligoamenorrhea at least 4 months, and FSH level should be more than 25 international units per liter, on 2 occasions more than 4 weeks apart. This is the statement of guideline, ESHRE guideline, and this is the recommendation how to make this diagnostic. Around 10% of women, as we have mentioned, are diagnosed with ovarian failure or ovarian insufficiency between 40 and 50 years old. In general population, it is approximately 1%, but in population of patients who come in IVF clinic, gynecological clinic, and fertility clinic, it is around 10-15%. So it's quite a big number, even 20%. So necessary to understand and educate patients that there are some modifiable factors which can increase the speed of how to say, losing this ovarian reserve, or some factors may just opposite to improve situation. For example, risk factors that can be changed and improve prognosis with ovarian reserve. It is lifestyle factor, healthy lifestyle, it's understandable. Smoking, if women stop smoking, of course, it may improve her situation and prognosis. Healthy diet, we will talk more about diet and what exactly improve or decrease the ovarian reserve, and some treatment protocols in oncology may be modified and may be more or less aggressive to ovarian tissue. Also, factor cannot be changed. Okay, I have put plus and minus because it depends. For example, surgery, it may be modifiable if you discuss before surgery with a doctor that you would like to keep the maximum ovarian tissue, or another situation when it is urgent, surgery, and okay, doctor do what he can in this moment. So these factors at right part of slide, more or less modifiable, but sometimes not. It is genetic, of course, you cannot influence, but as a factor, in some point, you can modify also. It is surgical interventions, oncological treatments, autoimmune disease, and infections. Mm. Factors which related to earlier age of natural menopause. According the articles and scientific investigations, it is low socio-economic status, probably because on not good diet, probably, but maybe because on stress. It's difficult to say exactly. Also, low parity, it means not a lot of children, not a lot of delivery, not using oral contraceptives, and active smoking. Factors related to earlier age of natural menopause. Another factors may also influence the age of menopause. It is race and ethnicity. We will talking later. Body mass index, very low body mass index and very high body mass index. This extremity may provoke premature ovarian insufficiency. Little bit overweight, it is just opposite, may prolong reproductive age, probably because on estrogens synthesized in adipose tissue. Physical activity, but not enormous physical activity, may improve situation, and diet. So let's talk a little bit about diet. It is interesting question because classically we know that diet should be, how to say, very healthy, a lot of fruits, a lot of legumes, a lot of nuts, beans, but surprisingly, the vegetarian diet in some scientific publications shown to decrease the age of menopause, provoke early menopause. Vegetarian type of food related to premature ovarian insufficiency. Also soya products, cereals, fibers, refined pasta and rice, phytoestrogens also, but mostly in study with animals model. Also high fat diet, more than 40% of all calories from fat, from lipids, may contribute to increased risk of premature ovarian insufficiency. Late menopause, it is not to be vegetarian, or in another study, healthy plant-based diet, but well balanced with enough quantity and quality of proteins. Probably that's why it is so contradictory. From one side, they write that vegetarian type of food provoke early menopause, and from another that late menopause. Yeah, so probably the question is about well balanced and rich in protein and micronutrient vegetarian diet, which is quite difficult probably to organize, more difficult than standard diet. Also high intake of vegetables protein and higher fruits intake. Also, early and late menopause, we have discussed about body mass index, and we can say that there is a link between body mass index and ovarian failure. This link is still unclear. Very low body mass index may provoke earlier ovarian insufficiency. But with high body mass index, in some publications, it is rather beneficial. Also, we can say that early menopause related to some ethnicity, like African, Latin America ethnicity, low weight, and surprisingly low IQ associated with earlier menopause. European ethnicity written to be related to more late menopause. Also, physical activity, little bit overweight, and high socioeconomic status. So, what we can do in this situation? What we should do? So, if we have this condition, if we meet patients with premature ovarian insufficiency, we have high level of FSH, a low level of IMH, necessary to see if there is some genetic problem. Necessary to propose patient to do karyotype, because like that we can detect Turner syndrome. And it is important to know because, for example, if people with Turner syndrome would like to become pregnant, they have some specific complications and specific algorithm of control and investigation. Also, we can have situation when we detect karyotype XY and female phenotype. In this case, necessary to discuss some surgical intervention, because in this case, this ovary may be more prone to oncological disease. If we will found fragile X mutation of FMR1 gene, necessary to discuss this situation with genetic, because there is a risk to have some health problem and mental retardation in children of this woman. Also necessary to see if there are some autoimmune problem, because in this case necessary to be controlled by endocrinologist. In case we have our diagnostic, the main treatment is to restore the level of estrogens and progesterone and prescribe hormonal replacement therapy. Estrogens, which we can use, exist in 3 types and are available in different form, like tablets, like capsules, and also transdermal forms. Estradiol, the main ovarian estrogen, is beta estradiol, is active component of this estradiol. Probably the best choice for replacement hormonal therapy. Progesterone is need if woman has uterus, and it is necessary to protect lining from hyperplasia or cancer. So, indications. Very often, women who has ovarian failure asking if there is really indicated, or I can choose, for example, or in which case it is not recommended. So generally, the indication of replacement hormonal therapy according guidelines is if woman has vasomotor symptoms. In this case, replacement hormonal therapy will be very helpful. If woman has genitourinary symptoms, problem with sexual life, problem with feeling of lack of estrogens and problem with sometimes we can have even symptoms like inflammation, like cystite, So in this case also it will be very helpful. Also bone health, for sure replacement hormonal therapy will give the better prognosis about normal bone density. Also cardiovascular health and sexual function. When we are talking about life expectancy, in this case, probably it is still early to say that we should prescribe replacement hormonal therapy. And quality of life, also, this is a difficult question, and for each person, it is how to say, necessary to understand what she mean about this term quality of life. So if really a woman has symptoms and would like to improve some situation, in this case we can prescribe replacement hormonal therapy. Beta estradiol seems to be the preferred to ethinyl estradiol or other preparations. Women should be informed that micronized vaginal progesterone is better than dydrogesterone standard by combined treatment in tablets. And also recommended to continue replacement hormonal therapy approximately till the age of normal menopause, around 50, 52, 54 years old. What is the monitoring of this hormonal therapy? Currently, there is no evidence regarding the optimum monitoring strategy. We should understand that estrogens theoretically may influence lining, uterine lining, breasts, so necessary to do as minimum ultrasound, mammography, also control the bone density, and if there are some symptoms or some problem, necessary to control this problem. About the risk of thrombosis, of course, steroid hormones may some relations to this risk, but necessary to know that transdermal or vaginal forms give less risk of thrombosis than tablets which we can take per os. Also, often people asking about alternative to replacement hormonal therapy like psychotherapy, homeopathy, relaxation technique, acupuncture, herbal medicine. So all these methods, of course, will and may be helpful, but necessary to understand that they will affect mainly the symptoms of sex hormone deficiency. It means that probably improve sleeping, probably improve mood, but for example will not influence the bone density or will not influence cardiovascular system. So what about diet and supplements? As we have mentioned, estrogens have protective effect on our health, and when we have not enough of estrogens and progesterones, we can try to take melatonin because on this molecule regulate sleeping, and we know that one of the main symptoms during the menopause is sleeping disorder. So melatonin may improve sleeping and has also antioxidant effect. Also, we can take mitochondria targeted nutrient like coenzyme Q10. Also, there are some articles which show that coenzyme Q10 may improve situation with ovarian reserve and improve the quality of eggs. Also recommended to eat a lot of oily fish of Northern Sea. Also, dairy consumption, it is thing to be beneficial for bone health and also for mm, menopausal symptoms, and also recommended to take vitamin C and E as natural antioxidant. What about reproduction? First of all, necessary to say that from 2.5 till 5% chance of spontaneous pregnancy within a year after we have constated that FSH is high and we have some cycle disturbance. Even some authors written till 10% of spontaneous pregnancy may arrive after officially established menopause. Uh, Chance of spontaneous pregnancy is increased when hormonal replacement therapy was prescribed. Best chances to have pregnancy at the beginning of this period, and better when your FSH is lower. Sometimes immunosuppressive therapy may have beneficial effect and even restore partially your ovarian reserve. How to understand finally your ovarian reserve? In some observational study of very high number of cycle, 124, 1024, 700 cycles, and mostly 200 centers, doctors answer how they prefer to measuring ovarian reserve, and most of them choose FSH or FSH plus anti-Mullerian hormone or FSH plus antral follicle counts to control ovarian reserve of their patients. IMH, as for me, is better choice than FSH because level of anti-Mullerian hormone progressively decreased with decreasing of ovarian reserve. FSH, if you can see in the slide, stay normal level till the moment when menopause arrive, when ovarian reserve is totally, how to say, disappear. Um, Measurement of anti-Mullerian hormone is quite easy. We should understand, of course, that there is some variability of anti-Mullerian hormone, and it may be plasmatic variability, maybe laboratory variability, maybe variability due to pre-analytic working with biological material, but still anti-Mullerian hormone today stay the most reliable marker of ovarian reserve. And also necessary to know that low anti-Mullerian hormone does not mean and does not predict the oocytes quality. So if your ovarian reserve is still not very high, but okay, decreased, but we can still detect some follicles, and IMH show that it may be some follicles and eggs. Necessary, of course, try to take these eggs and try to do something with them, because in 6 months, in 1 year, these eggs may disappear. And low anti-Mullerian hormone does not mean that you will have bad quality eggs. Quality of eggs related mostly on age. So egg or embryo banking is the best options is there is no final depletion of the ovarian reserve. So necessary to know about that and speaking about that with your doctor. So, if ovarian reserve is unfortunately absent, if no follicles, no eggs, the only one option we can discuss it is egg donation. The indication to egg donation, according the American Association of Reproductive Medicine recommendation, it is women with gonadotrophic hypogonadism. It means with normal words like menopause. Also for women with advanced reproductive age, when quality of eggs is decreased. Women who have very diminished ovarian reserve, also to women with some genetic condition, with poor oocyte quality, or for partners who has several unsuccessful treatment. And I would like to say a couple of words about egg donation for patients with Turner syndrome. It is karyotype 46XO, X0. For these patients, we can do egg donation, and most of them will have healthy delivery and have healthy live birth, around 80%, but they have some specific problem like more high level of preeclampsia, eclampsia, HELP syndrome. HELP syndrome, it is the liver failure during the pregnancy. Also, gestational diabetes is more often in this category of patients, and some specific condition as aortic dissection. Normally, before doctors start the preparation of to egg donation program with girls with Turner syndrome, it is mandatory to see the heart to control the heart health and to see if vessels has no this problem. Also necessary to thinking about very high risk of multiple gestations for egg donation generally, but for this category of patients especially. And also they has such condition as low birth weight. So at the end, I would like to do a little review. The general recommendations for patients with premature ovarian insufficiency: if they smoke, necessary to stop smoking, normalize weight, take vitamins and antioxidants like melatonin, vitamin C, E, coenzyme Q10. Also, thinking about replacement hormonal therapy in case of absence of contraindication. Also necessary to see your diet. It is not easy. Necessary probably to speaking with some specialist, especially adding oily fish, milk products, fruits, and to see that you have enough proteins in your diet also, vegetarian or not vegetarian. Also, vitamin C and E is important as antioxidant, and regular physical activity. And like conclusion, I would like to say that premature decline in sex hormones level has a negative impact on a woman's body, not only on sexual organs and some symptoms. It is important to detect a decrease in ovarian reserve earlier and offer some solutions like egg banking or embryo banking, and discuss reproductive plans. It is important to know about the factors that accelerate the decline of the ovarian reserve and those that increase the time of menopause. In the presence of even single follicles, embryo egg banking necessary to propose. in the absence of own oocytes, we can talking about oocyte donation or embryo donation. So, thank you for your kind attention, and I am ready to answer your questions.
Thank you so much indeed. Dr. Halyna Strelko was our presenter, of course, and this was definitely an interesting and thorough explanation of what we have been talking about today. So, premature ovarian failure. And now it's time for your questions. And of course, I see some questions, so we will go to them right away. However, if you have any more questions, this is your time. Go ahead. Don't hesitate. This is your time. So please type those questions in the chat. And let's have a look at the very first question that we have here. There will be some parts of this, so I will show you one by one. So my AMH is 3.2, which is very low, and I also have light periods only lasting 2 days. I only had 3 follicles in my last IVF round. Is there anything I can do to increase my follicles? Do you recommend priming or downregulation for increasing number of follicles? I'm 36. And let's go to the first part.
Okay, thank you. Very interesting question. And it is really a big problem to increase the number of follicles. I would like to say that follicles growing by groups, by waves. And it may be that, for example, at the beginning of your cycle, you have 3 antral follicles. And when your doctor will see you at the mid cycle, he will found 5. And at the end of your cycle, 2. So when we have very low number of antral follicles, necessary probably discuss with your doctor and choose the moment when you has more antral follicles. And in this case, your stimulation will be more successful. Down regulation in this case probably will not improve situation, which can be helpful with down regulation. When you have decreased ovarian reserve, your follicles grow in not very they are not synchronized. It means that you come second day of your cycle and your doctor see one follicle 12 millimeter, one 9 millimeter, and one 15 millimeter. And finally, stimulation, he starts stimulation, and in 2 day follicle, bigger follicle is ready and little follicle does not move. So you have 3 follicle, but at the end you have only one for egg collection, and this is the main problem. So down regulation probably may help to this, but better to do kind of pretreatment like estrogens pretreatment, progesterone pretreatment, maybe contraceptive pills, short pretreatment like 2 weeks, for example, or start your stimulation from the second phase of cycle. In this case, your pool of follicles will be more homogeneous. What we can do to increase, there are some works which propose to take coenzyme Q10, and sometimes it may be helpful. In 1-2 months we can see a little bit more follicles, and also replacement hormonal therapy, when you take it during 1-2 months, may decrease a little bit apoptosis of your antral follicles and at the end give you little bit more follicles, but it will not be double or triple. Yeah, so with all these interventions probably you will have little bit more, 1-2 more. The most important is choosing the best moment to start your stimulation.
Okay. Thank you so much for your first question. I hope that helps. And of course, if you have any follow-ups, this is your time to do it. And actually, I will go straight back to the same patient. So I'm taking CoQ10, 300 milligrams per day. Is this sufficient?
Yeah, it's a good dosage. In some publications propose to take 100, in another one 200.
Mhm.
So 300 it is quite big amount,
Okay.
but it will not change situation dramatically. really important to speaking with your doctor to choose the best moment to collect the follicles. Probably start from second phase of cycle, or probably doing two stimulation in one cycle, or doing egg banking, for example, 2-3 cycles consecutive, taking eggs, freezing, and then one day thawing, fertilized, and like that you will have more eggs.
Okay. Thank you so much for your follow-up and, of course, your advice here. And there are more questions coming up. So let me go to the straight one. Okay. To the next one, straight one, straight away. So is AMH of 0.2, 0.5 in age of 38, 39 a sign for premature ovarian failure?
Very good question. Thank you. Because there is no normal range of IMH. We discuss about IMH like depending what we would like to do. If you have no reproductive plans at age 39 years old, 0.5 IMH, it is more or less okay. But if you would like to do stimulation, 0.5, it means that you will have not a lot of follicles and not a lot of eggs, probably 5, maybe 4, maybe 6. But from the other hand, IMH has quite big variability. It means that if you will do this analysis several times, you may have different numbers, as you have mentioned, 0.2, 0.5. So necessary to see how many antral follicles you have in your ovary, and do it also not only once, but probably 1 to 3 times during the cycle. And premature ovarian insufficiency, it is finally menopause. So if you have some amount of antral follicles, it means that you have no still menopause, you have decreased ovarian reserve, and it is possible to working with your ovary and trying to receive follicles and have a pregnancy.
Okay. And is it normal that the AMH falls from 0.2 to 0.05 in 1 month at the age of 40?
Look,
This is the same patient, right? Sorry.
yeah, it is probably not the real fall. It is rise the variability of IMH level. There are three sources of variability. Real plasmatic level changing. It is intercycle variability around 30%, in some publications even 50%, and between different cycles maybe also 20-30% of variability of IMH level. Also, the level depends on pre-analytic. It means that if your blood stay in room temperature, for example, one half of the day before nurse or doctor put in the machine to study your IMH level, your real IMH level may increase around 40%. And there are another points which can really change your, how to say, final result of IMH. So this change is probably not real. It is rising due to this laboratory or plasmatic or some another variability, because IMH should be done with specific machines and only with specific equipment and specific um, laboratory dispositives. But sometime laboratory has one machine, but buy material from another company. It may be sometime. And in this case, your IMH level will be not exactly the same as with standard reagent. So there are a lot of points which can influence this result.
Okay, thank you so much. And I will go straight to the follow-up here. So could you show again the table variation of AMH depending on plasmic laboratory, etc.? Do you remember which you had it in your presentation, I think. So do you remember?
I will show you.
Let's go back to this.
Oh, just. Oh, this.
Okay. And
So,
remember,
yeah,
sorry.
if you have, for example, real plasmatic level 1, but with 3 points of variation, you can have from 0.5 till 2.5. It means that it may be quite different, the number, and necessary to see different markers of ovarian reserve. For example, antral follicle count, maybe FSH, uh, anti-Mullerian hormone, and do it several times, and in this case you will understand better your real ovarian reserve.
Okay. Thank you so much. I believe that helped. And of course, let me go to the next question here. So, can oral contraception impact ovarian receptors for FSH, LH?
Very good question. There are a lot of publications about oral contraceptives. Maybe 15, 20 years ago, it was very standard practice to give for 1, 2 months before the stimulation oral contraceptive pills and then start the stimulation. But then became a lot of publications about negative influence on ovarian response. It means that ovarian contraceptive pills decrease LH level, and ovary follicles need some amount of LH to produce normal healthy oocyte and to growing. Follicle need LH to growing, especially second part of cycle, second part of follicle development after the size of 14 millimeters. So with long time in contraceptive pills, we can see that ovarian response will be worse, and we will have less follicles and eggs of lower quality. But if we can take only few days, or for example 10 days or 2 weeks, we will not see these effects of contraceptive pills, and in this case even it may be beneficial because your pool of antral follicles will be more homogeneous. And also important which component progesterone is inside of your contraceptive pills. Some progesterones give more effects on quality of eggs, and some of them less. So it's, how to say, depends on exact name of these pills, how long you take, for what purposes you are taking these pills. So it depends.
Again, thank you so much. Okay, let me show you the next question, which is follow up here. Is there a possibility to figure out the ovarian sensitivity to FSH and LH?
It means improve ovarian sensitivity.
I believe so, yes. And of course, if you have any follow ups, go ahead, type those in.
If we are talking about improving ovarian sensitivity, uh, normally we're using for this purpose growth hormone. It is, how to say, a little bit out of label, but there are a lot of publications now about the effects of growth hormone on ovarian sensitivity to stimulation, and it may also improve the egg quality. Also, add luteinization hormone to standard FSH may improve the ovarian response to stimulation. Also, in some publications about some genetic changes, genetic mutations of FSH, LH receptors, written that if we have such mutations, necessary to increase the dosage because sensitivity of ovary or follicles are decreased. Ovarian biopsy probably will not improve a lot the sensitivity to FSH. Probably you mean that there was a method, and there is now, for women with polycystic ovarian disease, When we are doing what we call ovarian drilling, it is like biopsy, like points in ovarian capsule. In next cycle may improve the response to stimulation. It is, yeah, it's true, but it is rather for polycystic ovarian disease, not for ovarian failure, ovarian insufficiency.
Mhm.
It's the
Okay.
opposite problem.
Thank you. And the same patient, Lou, here has another question. So, are there any other options in addition to PRP method to increase the ovarian response? Maybe taking antra follicles and growing them in laboratory conditions.
Yeah, good question. There are some methods described in literature. We don't do them, so I have no my own experience. But in some publications, there is a method named activation of ovary. They take ovarian tissue, then add some chemical substances, and it is activate these stem cells in ovary, and then they put this tissue back. And okay, according to literature, it may improve for some period the activity of ovary. Mm, we don't do that. I have no my own experience. So if somebody doing in your hospital, in your town, in your country, you can try to do that. More, how to say, conventional methods. We can use growth hormone, as I have mentioned. Also PRP. Some publications say that it is helpful. We have tried several times. I have no very, how to say, high uh, not experience, how to say, I'm not very satisfied with this method. Couple of patients show good results, but most of patients not show a lot of improvement. So as for me, more, how to say, reliable is doing egg banking. For example, if you have 1 2 follicles every cycle, you can take this follicle in a more or less natural cycle, freeze eggs, and during 3 4 5 cycles receive 10 15 eggs and working with them. Anyway, it will be, as for me, easier and more reliable than all experimental methods.
Makes sense again. Thank you for this. Okay, next question. So why do ovaries stop the normal growing process of follicle under stimulation therapy, which aims to stimulate the growth? So actually the body reacts exactly the other way around as it should.
Um, okay, necessary to understand in which conditions ovaries stop to grow. It may be, first, if you have taken oral contraceptives during, for example, 6 months, 1 year, and after that start the stimulation. In this case, not enough LH, and your follicles will not developing. Also, it may be mutations of FSH or LH receptors, and in this case, necessary to add higher dosage or add LH or add growth hormone. Also, in long protocols, sometimes we can see such condition when doctors use only FSH, recombinant FSH, and with high suppression. In long protocol, we are doing first the suppression of ovarian function and then start the stimulation. And in this case, also we will have not enough LH. So when we add urinary FSH with some little amount of HCG and LH activity or recombinant LH, in this case, ovaries start to growing. So necessary to know the exact situation to answer you more exactly.
Of course, that's perfectly fine. And there are some more questions, like 3 of them, and we will be finishing. So if you have more questions, go ahead, take those in. And this one is a short question. How much melatonin should I take a day?
Um, Look, it depends on preparation because a different company give different melatonin dosage and in combination with something. So necessary to see which one you will buy. And normally they how to say produce by such way that you should take, for example, 1 or 2 tablets per day if it is like supplements. Normally it is organized like that. So it depends on what exactly you will buy, which kind of melatonin you will
Course.
buy.
Okay. If you have anything else to add, you know what to do. And Lou would like to know, so does artificial testosterone help to develop more and better follicles?
Yeah, it was a lot of works about testosterone, dehydroepiandrosterone at the beginning. Then it was saying that it is not helpful. Then transdermal testosterone, then saying that not helpful. So
Mhm.
uh, it is some contradictory information in scientific works about testosterone, but how to say, some amount of articles recommend to take transdermal testosterone or DHA during 2 3 months before the stimulation, and there are some works which show that it may be beneficial. uh, Okay. Also, it will not change dramatically the situation, but probably will help you to add 1 or 2 more follicles. But still, we can also try to do collection of follicles, freezing oocytes, collecting during 2 3 cycles, and probably it will be more easy than long interventions, 3 4 months taking something and not sure that it will be really beneficial.
Okay, thank you so much. And I will go back to the previous question and follow up from the patient. So, regarding ovary stopping growing follicles, this is the question we discussed. So, I have no FSH or mutation. Stimulation was done with both FSH and LH pergovaries and once pergovaries and clomiphene. Anything you can add here?
Yeah, also necessary to see your ovary at the beginning of the stimulation because
Mhm.
probably what your doctor thinking to be a follicle was not a follicle. For example, sometime we can see like little black spot, like little endometrioid cyst or something else, or some persistent follicle from another cycle. And in this case, of course, it will not grow in. Also necessary to see your ovarian reserve. Whatever you will take, but if there is no antral follicles, okay, will not grow in if there is no follicles. So normally in if it is really follicles and if they are start to growing, we can increase the dose. Also, what can be important sometime, if we choose the low dosage at the beginning of stimulation, not enough, not low but not enough for your ovary. After the process of apoptosis start in follicles, and even if you increase the dosage, follicles will not grow because normally follicle development, they need some amount of FSH to start the development, but after some point the process of apoptosis of follicles start and most of follicles, how to say, died, and only 1 or 2, the most sensitive to FSH, continue to growing. So if we start the stimulation with not exact and good dosage for your ovary and for your follicles, after the increasement of dosage may not be helpful. So it's difficult to say like that, necessary to see, how to say, more exact information, but probably one of these causes may explain your situation.
Okay. Thank you. If you have anything else to add, of course, you know what to do. And let me go to this question. So, can I do anything to increase my period blood flow as my periods are very light and only last 2 days?
Is it really necessary to increase? This is the question. Because
Mm-hmm.
sometimes short period may be due to very thin lining. And it may be the problem which will not be, how to say, resolved with medication. For example, you have damaged endometrium, and in this case, endometrium not growing well, and you will have a very light period. Or another possibility that you have decreased ovarian reserve, your follicles growing very quickly. At the beginning of cycle, your follicles are 12, 13 millimeters, high level of estradiol. And in this case, your period will be more, how to say, more blood, but more short.
Mm-hmm. Okay.
Also it may be like that. So necessary to see the endometrium thickness. If at the middle of the cycle your endometrium is at least 7-8 millimeters, no matter that period lasts
Mm-hmm.
only 2 days.
Okay. Thank you so much for your advice here. And of course, I think that again helped you, Asma. Thank you so much for your question. And let me go to the next question. We might see like two last questions here. Um, this is some information plus some questions. So
Mhm.
thanks again for so much valuable information. I would like to ask if there is a fluctuation in FSH, AMH, or TSH levels depending on period day blood test is done.
Yeah, sure. Now, for FSH, of
Mm-hmm.
course, will be fluctuation because normally for ovarian reserve testing, doctor asks to do FSH at second or third day of cycle. But when you have decreased ovarian reserve, second or third day of cycle, you can have, as we have mentioned, the follicle of 12, 13 millimeters and the estradiol level like 80 or 100. And in this case, your FSH will be low. But it will not be true because it will depend on high estradiol level. It will not reflect the depletion of ovarian reserve. So, if you will measure in FSH during the cycle, he will change because normally the function of FSH is growing of your follicle. It should be in normal situation low at the beginning of cycle and then growing, 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 and it will produce the growing of follicle, and then it will little bit decrease before the ovulation, then flush during the ovulation, then decrease, and then increase before the menstruation. So like that, like wave. TSH level not depends a lot on during the cycle, but TSH level not changing very quickly. For example, if you are taking the replacement hormonal therapy, necessary is minimum 2-3 weeks, uh, and only then you can do the control of your TSH level because it will not change very quickly. With FSH, it is more quickly. TSH, it is 3-4 weeks as minimum. IMH level, yes, during the cycle it may change. It will higher at the beginning. It will little bit lower mid-cycle and also higher at the end. But it is also individual because follicles growing by waves. It may be 2 or 3 waves of follicle growing during the cycle, and it depends how many little antral follicles size less than 8 millimeter will be in your ovary at the moment when you take your IMH level. And of course it will influence, and also all these points of variability at the moment when you have taken your IMH.
Okay, thank you so much. And I believe now we will go to our final question for today. So, when collecting follicles, would you prefer natural or stimulated cycle?
Mm. Look, if we have decreased ovarian reserve, like we can see at the beginning, 1 or 2 follicles, normally we are doing what we call modified natural cycle. We give some amount of clomid or maybe letrozole, something easy stimulation. And also we add antagonists and couple of ampoules of FSH. And when follicles arrive 18 millimeters, doing trigger and pick up. In this case, we use very low amount of medicine, but without medicine, it is very difficult to receive the mature oocyte because maturation starts 32 hours after the LH rise. But in natural, totally natural cycle, we are not able to detect this LH rise. We cannot measure in your LH every 30 minutes, and laboratory will not answer to us every 30 minutes. We will receive answer of laboratory in 2 days, but ovulation
Of
will
course.
arrive. So modifying natural cycle is the easiest and, as for me, the best way to receive eggs in natural cycle.
Okay. Thank you. One more question, and if you can look at this. So I missed this question. Where can I have IVF treatment with no age limit? How does it look like in Ukraine, for example?
Okay, officially we still have no age limit. There is some attempts of our parliament to do some
Mm-hmm.
reproductive law, but
I will
still
show you. Yeah.
they are not able. The
Mm-hmm.
problem of age limit with IVF, I mean, if we try to stimulate own ovaries, after 42, 43 years old, most of our sites has genetic problem, and we can receive them, we can fertilize them, but they will not give viable pregnancy. And
Mm-hmm.
this is the main problem of age limit. If we are talking about egg donation, of course, if women are in good health, has all controls, has a doctor who are ready to follow her in her own country, we
Mm-hmm.
can discuss the possibility to do the transfer. But
Okay.
necessary to see the exact situation.
Okay. Every case is different, obviously, and you need to have all the details before continuing, and of course, yeah, before
Yeah.
advising that it's possible. Mm-hmm. Okay. That makes sense, of course. Thank you so much. Yeah, so follow up here, right? So basically, if you obviously it's more details you need, but if you were to use egg donation, sperm donation, so it's possible. There is a possibility, but every case has to be,
Yeah, necessary to see the
of
exact
course.
situation.
Mhm. That makes sense, I think so. Thank you so much for all your questions. Thank you so much, Dr. Strelko, for your thorough advice and information as always. So thank you so much for that. And as you can see, more thank yous are coming up your way. And before we finish, I have a little bit of a survey for you today. This is a short one, so if you can simply have a look at this. So basically, we would like to ask you, and you can click it right now. So if there are any topics, we've never done this before, but if there are any topics you wish to discuss, please write to us. Let us know what kind of topics you wish for us to discuss, and we'll be happy to do it. So, this is your chance to simply type this in. You can do it now, but if not, you can always email me. My email address is in the chat, but also it's Caroline at EuropeanFertilitySociety.com. And please just let us know, because of course we are trying to gather as much information as we can, but sometimes we think that we would like to hear from you, our patients, and what kind of topics you wish to simply know or wish for us to discuss. And that will be amazing for us to know. So type those in. We still have time. And in the meantime, while we are waiting for your answers, but as I mentioned, you can always type this and send an email to me. But in the meantime, Dr. Halyna, thank you so much for today. Thank you for joining us, for your thorough explanation to this topic. And of course, before we finish, is there anything else you wish to add?
Thank you. It was really interesting. I like really this part of questions and answers, and I
Definitely.
would like to propose you a topic because
Okay.
a lot of questions was about the variability of IMH levels. So I think it will
True.
be the good topic for the next discussion.
Thank you so much indeed. That sounds like a good example as well. And I also see your some of the Asherman syndrome may be interesting. Endometriosis through AMH variability is a very good
Yeah,
idea.
very good idea. Yeah.
Definitely. I have it all. And actually, I would, just in case, so I will not forget, I will do this. I will just share this here because, of course, karyotype results, understanding. That's great. Thank you so much, guys. This is really helping. And that's why we wanted to do it, because of course we want to hear you. We are here for you, and of course it's great to have your ideas. And I'm just saving them all because I see that you are putting those in the chat. So thank you so much. And Dr. Halyna, definitely it's a good thing to discuss. So I'm looking forward to some more events with you. And just so you know, we will be back with some more events. And actually, this week we are celebrating our almost our 500th webinar. So we will be back next week. Sorry, actually tomorrow. Sorry, it's just habit. But we will be back tomorrow on Wednesday. So we will talk about art techniques for women of advanced maternal age. So if this is something that you are interested in, join us and we'll be happy to have you and discuss it. Dr. Halyna, thank you so much for joining. It's been great to have you. And let me just remind everyone that Dr. Halyna Strelko is the CEO and founder of IVMED Fertility Center in Kiev, in Ukraine. So thank you so much for joining us. It's been great to have you. I'm really looking forward to some more events with you. And
Thank you.
I'm
It's
always
always
happy
my
to.
pleasure, and hope
Definitely.
hope it was interesting, and hope patients receive some answers. So
Definitely. I'm
see
sure
you
about this.
next webinars.
Thank you so much indeed. Thank you everyone for being so involved in this, and of course we wouldn't be able to do it without you. So thank you so much for your suggestions. We will definitely take those into consideration. So stay tuned. There will be more webinars, and I hope to see you here tomorrow as well. And if you have questions, you know what to do. Just join us and type those questions in the chat. Thank you so much. Take care. Have a good night.
Bye bye. Bye bye.
Bye.